Ladies and gentlemen, Mr. Chairperson, good morning to all of you. Today my case is below knee intervention. He was a 60-year-old male who had known healing foot ulcer. I did his angiography, which revealed that there was a subtotal occlusion of popliteal artery. Just give me 1 minute, please. A subtotal occlusion of popliteal artery. So I realized that the calcified vessel and taking multiple views, I tried to find out, after putting the catheter below, I found there was one right angle vessel arising, posterior tibial artery was right angle vessel arising from the lesion site. It was difficult to cross to that right angle vessel, but I realized right angle vessel was better vessel to cross. So I was trying to cross the vessel, but I could not cross in posterior tibial artery. So finally, after taking the support of the catheter, I was able to cross only to the anterior tibial artery, which was distally diffusely diseased. But my aim was to cross to the posterior tibial artery arising exactly right angle and were diseased at the ostium. There was no way to cross this vessel. So finally what I did was I crossed to anterior tibial artery itself and then dilated that area. I tried multiple ways, I could not cross that vessel. So I went to anterior tibial artery and dilated that area of the lesion site. This was a balloon at the bifurcation. Now I could find that flow was better in posterior tibial artery to the right angle. But the posterior tibial artery was a better vessel to cross with a better distal lumen. There was no way to cross, so I found a different technique. What I did was I took a multipurpose catheter, and in multipurpose catheter I made a side hole in the multipurpose catheter. The wire which was an anterior tibial artery, I backloaded that wire from the side hole of multipurpose catheter to the posterior end. So I advanced this catheter on the anterior tibial vessel, which was not coming out from the actual lumen. It was coming out from the side lumen. Now once this catheter was at the place where bifurcation was there, then I could cross easily to the posterior tibial artery. So the main key point in this case was how to cross at right angled vessel at the lesion site, and this was important in this case because the vessel was a good lumen. Then case went easily. Then I went with the bifurcation, then I went to the stenting of that area. I did multibilateral and distally also, and finally I stented across that bifurcation, which was a simple coronary stent because the below knee size was about 3.5 in 20. After dilating the vessel, then I recrossed, there was a good flow at the side, and then I recrossed anterior tibial artery and then did finally kissing balloon. I did finally kissing balloon below knee and finally got reasonably good result, and actually patient had good healing of his foot ulcer. So message in this case was that we have to select whichever vessel is better out of two. At being a right angle region from the anterior tibial artery, it was difficult to cross. The best method could have been that after crossing to anterior tibial artery, I should dilate the balloon there, one occluding anterior tibial artery, then we can direct the wire to posterior tibial artery, which could not work in this patient. So I did a side hole in multipurpose catheter, backloaded the wire and did direct the catheter from that side.
Good. Very well presented, and this just goes to show what Dr. Dhar was saying, that we should repeatedly try to attempt these vessels. It's just not just that we straight away say that it's stem cell. You know, we get such results in vessels which actually don't look very good when you do the initial angiogram. So an attempt should be made always to try and get into these vessels.
Here I would like to, what you were saying, that only one remark was I would like to make, that in seeing this type of arteries without trying, just going for the other method, that is I don't agree. And second thing is that when you are coming from a the center where Ashok set is there, it will be a very much unset-like attitude to leave it just like that and give it for the for the stem cell therapy.
And the other thing is, unlike the coronaries, the success rate of crossing these coronary occlusions in the periphery is much higher.
It is a very standard thing. So, but only in this case, once doctor you found that the posterior tibial artery lower part lumen is there, why didn't you try once to go from the ankle, just do a retrograde puncture at the posterior tibial artery, and you could do all the things from that approach what you did. And third thing, what I would not like to do here is a stenting, because stenting is very uncertain below knee. There are many complications, fracture and other things are already there in the literature. So you could use perhaps a cutting balloon or a scoring balloon for the coronary arteries.
Okay. Second one?
Yeah, I just take small 2 minutes for this case. This was basically complication of renal artery angioplasty. Simple case, I was doing renal artery angioplasty, just forgot clinical history. And this is right angle region. I just pre-dilated the lesion site with the BMW wire and the 2.5 millimeter balloon. And finally what happened was that this was right angle region. I don't do usually deep throttling of the guide, because it usually happens what is causes this it usually causes atheroemboli. Then I was trying to put the stent. Stent did not go in spite of all of whatever I could do. I took in different views to decide whether I am in or out. Stent did not go. And finally, actually, I dislodged the stent. Balloon still in the, I was trying to withdraw back into the guiding, but it did not go. And finally that stent was on the wire. The stent was hanging on the wire. If you can see, it's near the guiding. Stent is near somewhere near the guiding. Stent is there. Stent is somewhere here. Stent is somewhere here. Now I had different ideas to withdraw the stent. What I did was, first I took a small stent is near the guiding tip, somewhere here. I took 1.5 millimeter balloon, went through the stent, went on the wire through the stent, inflated the balloon at the distal end of the stent to try to put it as a total assembly, but it did not come. Then I took a bigger balloon. I just tried to take the balloon, inflated balloon, it did not come, because stent was slightly inflated. Now I took a bigger balloon and I was trying to withdraw the stent, and balloon slipped again. Balloon popped out of the stent again. So stent was still hanging in on the wire. Now I thought of taking it out with a snare. Once I was taking it out the snare, the stent got crumbled. And I tried to withdraw as a total, but it did not come in the sheath too. So stent was at the mouth of the sheath with my snare held on. Well, now what should I do? Then I called surgeon to take him out. Obviously, there could have been other ways also, but it was already crumbled, it was jumbled mass of metal.
What I would like to tell you that about the last case, just a minute, I was talking to you that again I am telling you that below the knee, if there is some severe dissection or something, not to put a stent and use a scoring balloon or a cutting balloon. And second thing, in this particular case, you had seen that there is a 90-degree angulation is there. What I would have done, I can tell you, that do the pre-dilatation, take the guiding catheter tip beyond the stenosis, and then push the stent and gradually pull it back up to the position and inflate it.
This is what I was saying. I don't do usually because it causes atheroemboli, but obviously once retrogradely realizing it could have happened, that there could have been a better choice. Yes, I do agree. Once we dislodge the stent, then I think it's a better choice could have been to go into that renal vessel.